Okay, let us start. Good evening, everyone. I would like to invite you in this webinar organized by the pediatric section of EANS. My name is Rally Fritsch. I'm chairman of the section, and I have a pleasure to present a very difficult topic today, which is childhood-onset craniopharyngioma. And when we were thinking about this topic, we saw that, of course, this is a surgical topic, maybe in the first place, but knowing how difficult disease it is for children and their families, and how important are the outcome measures and medical measures, we also were very keen to invite experts that could give us another expertise, another perspective. So I will be joined by my co-moderator Rafael Guzman later on. In the meantime, I would like to welcome Sergei Oreshev, a professor at Budenko Institute, an institute where they have a vast experience with craniopharyngioma. So I would like to invite him to give us his first talk. Thank you very much.
Okay, do you see my presentation?
Yes.
Yes. So I will speak about the surgical approaches to the craniopharyngiomas, and I will focus on the transcranial approaches. So I think that you know very well this very famous picture by Rotten, and of course we have no time to thoroughly discuss all these approaches, but I will focus on some of them. So all the approaches depend on the localization of the craniopharyngioma. We differentiate several types of craniopharyngiomas: the endosuprasellar craniopharyngiomas with the origin in the sella, craniopharyngiomas of the pituitary stalk with the origin at this place and with the primary, which primarily destroy the stalk of hypophysis. And the third very important part is the intra-extraventricular craniopharyngiomas, which originate in the hypothalamus, in the floor of the third ventricle, and primarily destruct the hypothalamus. So all of them need different approaches, and we shall start with the subfrontal one. So the main indications for the direct subfrontal approach are the antecellar part of the tumor, the antechiasmal craniopharyngiomas, and to the nodules under the frontal lobe. We have several ways to reach the retrochiasmal part of craniopharyngioma, which we shall speak a bit later. So the skin and bone incisions for the subfrontal approach is shown on this slide. The bifrontal approach now is used very rarely, only for the very giant tumors. Sometimes we may use the endoscopic assistance to reach the different parts of craniopharyngiomas. For example, for the view of the suprasellar area, or vice versa, to view the intracellular part of the tumor. So, and these are some examples of how it is performed. This is a Aegean craniopharyngioma under the frontal lobe, and we use the endoscope assistance. We use the angled instruments in order to reach this part of the tumor. And the opposite situation, when we may look into the cellar and from the same approach, and to remove this part of the tumor with the angled instruments, angled forceps, angled coagulation, and completely remove the tumor from this part, from this place. So, and now we may use the subfrontal approach to come to the retrochiasmal part. So there are four possible routes how to achieve it: the translaminar terminalis way, the subchiasmal way through the optico-carotid triangle, and laterally to the carotid artery. So the translaminar terminalis approach is shown here. So as for me, I don't like it because it needs it. So you have to displace the frontal lobes very prominently. So, but nevertheless, in some cases, this part of the tumor, retrochiasmal part, may be reached only with the help of this approach. So the optico-carotid triangle approach is the way between the chiasma and the carotid arteries. So, and again, you may use the endoscopic assistance to look behind the chiasm and to reach this part of the tumor and to remove it, because this space is very narrow. Pterional approach is used when the tumor in cases of tumors in the middle cranial fossa, for the tumors for the retrochiasmal localization, for suprasellar craniopharyngiomas, which are shown on these slides. So this is the skin and bone incisions for the pterional approach. It gives more wide view to the retrochiasmal space and to the third ventricle, to the basal part of the third ventricle. But it is more complicated. It needs the dissection of the pterional muscle, the resection of the lateral sphenoid ridge, but nevertheless, it may be used for the removal of this part of the craniopharyngioma. Transcallosal approach. So some words about the geometry of this approach. So this is the bone flap. This is the dura incision. This is the fenestration of the corpus callosum. And this is foramen Monro. So this is the most posterior view to the third ventricle. This is the most anterior view. And you may see that this part of the third ventricle craniopharyngioma may be removed with the help of operating microscope. But this part cannot be viewed. For this purpose, we again may use the endoscopic assistance with the angled optics and angled instruments in order to remove this part of the tumor. So this is the geometry of the transcallosal approach in the frontal view. And we have to keep in mind that the ipsilateral part of the tumor has no such good view as the opposite one. So this is the skin incision. We may use the linear or S-shaped incision. The small craniotomy, 4 to 5 centimeters at the level of the coronal suture, usually on the right side, extended 1 centimeter across the midline. Arched dural opening with the base toward the sagittal sinus. All veins have to be preserved by careful dissection, but if needed, small bridging veins can be resected to retract the brain. Keep in mind that ventricular puncture is necessary in the majority of cases, as nearly in all of these patients where we use the transcallosal approach, there is a hydrocephalus, which should be resolved just in the beginning of surgery. Minimal retraction of the brain, we use the spatula, but we have never seen any complications when we use the spatula, as we can read in some publications. So in the bottom of this approach, we shall see the corpus callosum with, it is some white structure, and pericallosal arteries lying just on the corpus callosum. And please not mix them with the callosum marginal arteries, which are basically lateral to the pericallosal arteries. So there are 3 possible entries to the lateral ventricle. To the right lateral ventricle, to the left lateral ventricle, and just to the third ventricle through the septum pellucidum. And there are 3 corridors to access the third ventricle. This is the intrafornical one, the access through the choroid fissure, and through the foramen Monro. So the last one provides the natural corridor into the third ventricle. So here you may see again the geometry of this approach. These are 2 foramen Monro seen from the both sides. And on the bottom picture, there is a transfornical approach. And you may see that the bodies of the fornix are displaced to the left and to the right side. So these are the general steps of the transcallosal approach. And there are several stages. So this is, you may see the foramen Monro, then the flow of the third ventricle, and at the end of surgery, you even may see the basal artery and the prepedunculus cistern. So this is the main direction of the transcallosal approach. Sometimes we use the combined approaches. So in the tumors which are in the third ventricle and on the skull base. So if we use the transcallosal alone, we can remove this part of the tumor, and this part is invisible. So if we use only the subfrontal approach or any basal approaches, we may remove this part, but not this one. And only in cases when we combine these two approaches, we may reach the gross total removal. So this is the skin and bone, skin incision and bone flaps when we use the combined approaches. And some words about the peculiarities of the transfontanel approach, which is used in children less than 1 or 2 years old. The craniopharyngiomas are very rare, but nevertheless, we faced with these situations several times. And here you may keep in mind that there are 2 layers in the fontanelle, the layer of the dura and the aponeurosis, and these 2 layers perform the unique tissue. So keep in mind, when you dissect, you will see the only 1 layer, but not 2 ones. And the second point is sometimes we have to resect the part of the frontal bone. Transcortical approach. The transcortical approach, the principles of the craniotomy are the same, which we discussed for the transcranial one. We perform the cross-dural incision. Then we perform the gyrus incision in the middle frontal gyrus. Approach to the lateral ventricle is shown on this picture. You may see the anterior part of the third ventricle, but we have to remember that it is much more lateral than the transcallosal approach. That's why we shall see the lateral part of the third ventricle much better than the ipsilateral one. And these are several steps: gyrus, incision of the gyrus, and the view to the foramen of Monro. So the advantages of the transcallosal approach are the absence of the cortical injury, the access to both lateral ventricles, good visualization of both walls of the third ventricle, but it has some disadvantages, which are shown on this slide. So the supraorbital approach. It is from the family of the keyhole approaches. It is performed through the eyebrow, and this is the size of the skin incision, the bone flap, and the size of the dura, of the dura incision. Usually we use the special instruments for the keyhole approaches with a special handle. And this is a short example of how we use it. This is the cystic craniopharyngioma. You may see the right optic nerve. We use the routine microsurgical instruments, but with the fixed endoscope. Endoscope is fixed in one of the angles of the operating field. And only with the help of the endoscope, we may remove the craniopharyngioma, again, both from the basal part and even from the sellar part, if it is needed. Advantages is the minimal skin incision, the minimal bone incision, traction of the brain structures, but it is very narrow corridor and impossibility to change the direction of the approach. The subfrontal interhemispheric approach. So this is an approach to the most anterior part of the third ventricle, which, as I have shown you, actually is not very well seen with the help of the transcallosal one, both with the subfrontal one. So this interhemispheric approach is performed in the cases of the tumors which are situated in the anterior part of the third ventricle. So this is the direction. It is performed under the corpus callosum without its destruction and above the anterior communicating artery. So this is the skin and bone incision. It may be a bit difficult to dissect both hemispheres. It's much more difficult than in cases with the transcallosal approach. But nevertheless, it is possible. There is a frontopolaris arteries on our way. And at the end of this approach, we shall see the chiasma, the anterior communicating artery, and the pericallosal arteries. So, and this is the subcallosal arteries, which are very important to preserve. We never use the dissection of the anterior carotid artery, as it is published in several papers. We perform the fenestration of the lamina terminalis. Then we see the craniopharyngioma. And after its removal, we may see the basilar artery with its branches. Advantages of this approach is the good exposition of the anterior fossa, the sellar region, and third ventricle. So just in the pure midline and from above view. The excellent view to the anterior part of the third ventricle, and this is the extracerebral approach with any destruction, with the destruction of any countries, any structures. But it can be technically a bit difficult when we perform the interhemispheric dissection. So I have spoken about several of the approaches to the third ventricle and to the basal part of the craniopharyngiomas. So, and all of these approaches you may choose in the after the analysis of the MRI scans, and in different patients need different approaches to the craniopharyngiomas. Thank you so much.
Thank you very much, Sergey, for your exhausting overview. And I will ask my co-moderator, Professor Rafael Guzman, to present the next speaker. Please, Rafael.
Yeah, thank you very much. Thank you, Sergey, for a wonderful lecture. It's my honor now to introduce Professor Giuseppe Cinali, well-known by everybody, well-known expert for endoscopic approaches to the skull base, leader of many courses, and currently the director of pediatric neurosurgery at the Santo Bono Children's Hospital in Naples, running the courses every year that many people of the whole world have attended. And so it's a great honor to have you, Giuseppe, present on the surgical perspective with focus on the endoscopic approaches, please.
Thank you. Thank you. Can you hear me well?
Yeah, we hear you perfectly.
Thank you so much for your introduction. It's very difficult to talk after Sergey Gorelishev, who is a fantastic teacher and speaker and one of the pillars of our webinars, of our workshop in Naples. So we will talk about the endoscopic approaches. We know that there is some histological differences with adamantinomatous histology preeminent in children and adolescents if compared to the adults. The classification of the craniopharyngioma has gone through many histories, and we are now stuck, especially in pediatrics, to the very simple and effective classification of Stéphanie Puget with the type 0 intracellular infradiaphragmatic, type 1 supracellular, and type 2 hypothalamic involvement. And there is also the endoscopic endonasal surgical classification of Amit Kassam, who recognized the type 1 preinfundibular, transinfundibular, and retroinfundibular, that for skull-based surgeons and endonasal surgeon is very important to decide the corridor. Prognostic factor, as we know, The favorable is the lack of calcification, the extent of surgical resection, Caucasian race. Unfavorable is the age, young age, a very big size, and the presence of hydrocephalus. We all know this prognostic factor very well, but we all agree in the last 10 or 15 years to the therapeutic goals that is the cure of the disease with the functional preservation and restoration. This is not so easy, and the controversy that is still in being now is gross total removal versus subtotal followed by the radiation, and then the timing of radiation. Should we do it immediately after the surgical resection, or should we just wait for the evolution after surgical resection? We know that the hypothalamic dysfunction is the ghost that is behind us and is driving all our decision. That is the thing to avoid as much as possible, and we have to respect the hypothalamus and avoid excessive damage to hypothalamus. So how did the endoscopy impact on the treatment of craniopharyngiomas? Endoscopy can be done in different ways. In 1995 is probably one of the very first paper from Abdullah and Kamert of 3 cases that treated the endoventricular with 2 complete removal and 1 endoscopic fenestration. Indication for the endoscopy is a minimally invasive technique for a palliative conservative treatment for the craniopharyngiomas, but can perform tumor biopsy, cyst fenestration, management of hydrocephalus, implant of intracystic catheter through the ventricle, and in case of intraventricular tumor, the small intraventricular tumor without excessive hypothalamic involvement can also bring, in rare cases, to tumor removal. That instead is much more frequent in infradiaphragmatic cases treated through the nose. The advantages, of course, is less invasive than a craniotomy, and there is a better anatomical corridor through the nose if compared to the very complex, fascinating, but very invasive corridors that have been described by Serge in the presentation just before me. The disadvantages is, of course, is limited surgical maneuvers and bidimensional visions. So to resume, the options that endoscopy offers is the transventricular and the endonasal, and these can be combined, of course. So we will address the transventricular. Before transventricular approach, in the time there was a prerequisite of ventricular dilatation, intraventricular lesions, and significant cystic component. In fact, the ventricular dilatation is not very significant, very important prerequisite. Sorry about this. And the maneuvers that are possible through an endoscope through the ventricle are the biopsy, cyst perforation, implant of a catheter for fluid aspiration, removal of the cyst wall if intraventricular, and the catheter implant can be done also in case you want to use the protocol of the intracystic interferon, and then the complete removal for rare intraventricular craniopharyngiomas. So visualization of the capsule, introduction of the monopolar, perforation, introduction of a catheter inside the cyst, and in case of palliative surgery, perforation of the lower pole of the tumor cyst, and in order to have a perfect fluid communication between the ventricle, the internal part of the cyst, and the cistern below this. This technique was proposed by Alberto dell'Itala now almost 20 years ago, and he was doing that with the flexible scopes that is now disappeared in Europe because of problems of regulation. And out of 7 patients, he had treated 4 primary and 3 recurrent with very, very good results. But of course, this was in elderly people and not in children. One of our very, very first cases of endoscopy many years ago was this case. It came to us 2 years after partial removal in another center. We treated the cyst with the hydrocephalus, as you can see, with the very, very old endoscope, making a perforation in the wall and just preparing the child, resolving the hydrocephalus. This is after the endoscopy, and then preparing the hydrocephalus to a complete microsurgical removal because the patient was already completely pan-hypopituitaric. And then we had a second case a couple of years later, 2 years ago, with an occasional finding of a craniopharyngioma, small calcification in the infundibulum and a small cyst in the third ventricle after a head trauma. This you can see the craniopharyngioma. This is the contrast enhancement in the infundibulum. At that time, this also is give to you historical perspective. With this small fiberscope, we're really doing very difficult things, but in these cases, we were pure intraventricular form without the perforation of the floor of the third ventricle. We were able to remove the tumor completely, and the patient is completely tumor-free after more than 15 years of follow-up with a very, very small approach. So it is very interesting. This you hardly can see the scar of the passage. Then, of course, at that time, there was also the endoscope-assisted microsurgery. We are still quite historical in the development of the endoscopy. In very complex cases, with there are blind spots, like in this case, a very large tumor, the microsurgical approach is mandatory. How to reach the tumor that is into the posterior fossa, how to reach the tumor that is hidden. With that, only with the endoscope, as already nicely shown by Serge, you can approach after removal of the tumor. We can check the posterior fossa with an endoscope, getting a view and being sure of the complete removal of the tumor, even into the posterior fossa. And then we can do the same thing at the level of the subfrontal area, and we can even work removing the small residual infiltrating the hypothalamus. This was some kind of surgery that was done 15 years ago. Now probably we would not be so aggressive. This patient went very, very well, but at this time probably we would be much more conservative in this case, and we would remove this part that is infiltrating or very adherent to the hypothalamus, and just left it for the radiotherapy. Then we can combine the two options. That means in some cases we are obliged to do both procedures. The transventricular, if there is a very acute form of hydrocephalus, like in this case, 11-year-old girl with a significant visual loss. In this case, we were obliged to treat the hydrocephalus and to decompress the cyst very quickly in emergency. Still, you can see the very bad vision that was available approximately 15 years ago. But then, fortunately, we have very close to us the department of Paolo Cappabianca and Luigi Cavallo, with whom we cooperate very well, and they can do the endoscopic transsphenoidal removal of the largest part through the cella below the diaphragm of the cella turcica. So without expanding our removal to the area that is infiltrating the hypothalamus, and then sending the patient to the radiotherapy. We have reviewed with the group of the Federico II University the endoscopic endonasal approach for infradiaphragmatic craniopharyngioma, multicentric Italian retrospective studies. Out of 84 patients, almost half were identified as pediatric cases, and the gross total resection in these 50% of the cases was achieved in 54 cases. That means 64%. That means basically not very different from traditional microsurgical technique, and some endocrine, visual, and hypothalamic functions deteriorated in 52, 5% and 16% respectively. So it's a surgery that is not without risk and not without complication. And of course, there was a 33% of recurrence during follow-up. So certainly very nice result. This is a real-world photograph of several centers in Italy treating craniopharyngiomas through the nose, and certainly in the real world, the endoscopy through the nose, also because of a very significant variability of infradiaphragmatic tumor, we can conclude that this is, for the moment, a very useful technique and minimal invasive, but certainly the endoscopic endonasal still is not the final solution in the real world, as claimed by some endonasal fanatic surgeon. So it is a very, very good result, minimal invasive, fantastic advantages, probably lower rate of hypothalamic complication, but certainly not the final solution. Another final solution, or hopefully final solution that has been claimed, was the cavitron for endoscopy. That has been a significant tool introduced in the surgery. Through the bar hole, we can introduce the endoscope, and through the endoscope, we can introduce a cavitron that has been designed to work in a very, very limited ventricular environment. After adjustment of the trajectory, we introduce the cannula, and we can suck the fluid of a cyst and aspirate the solid part of the tumor. And of course, the tumors like this with a cyst and a solid part can be very nicely addressed. When there is a very large cyst inducing hydrocephalus, we can have a situation like this, a large foramen of Monroe. Touching the cyst and activating our endoscopic cannula, we can aspirate all the fluid, avoiding any contamination. Then we can remove the upper part of the pole of the cyst, and we can address our cannula to remove only the part of the tumor that is floating inside the ventricle. Like in this case, this is the posterior part of the tumor cyst that you can see very nicely separated from the ependyma of the hypothalamus. We do not touch the hypothalamus. We stop our resection only of the floating part, and we can obtain a subtotal removal, as it is largely recommended by the European Society of Pediatric Neurosurgery. And just sending this small residual calcification infiltrating the hypothalamus to the protons or to the radiotherapy as soon as possible without waiting for further exploration. But you can see that the amount of tissue removed can be very, very encouraging with the endoscopic ultrasonic aspirator. In other cases like this, it's a bigger tumor, but in this case, it was a very comfortable situation with a very, very limited infiltration at the level of the infundibulum. So after a significant aspiration and complete removal of the fluid of the cyst, we were able to identify nice boundaries between the wall and the hypothalamus itself. And in this case, we were able, with the endoscopic cavitron, to remove completely the tumor without any craniotomy, and only with a single bar hole, with a single step procedure. Very nice surgical result, but pan-hypopituitarism. So also in this case, it is very elegant, it is very minimally invasive, but the complication at the level of the endocrine function still persists if you perform a complete removal. And there is no doubt about it. If you remove completely the tumor, you will have severe endocrine complication. Not hypothalamic in this case, fortunately, but severe endocrine complication. This is the pre-op and the post-op. We found very effective and very useful the use of the endoscopy in the management of small residual and in recurrence. For example, in this case, who was treated with the first surgery just to decompress the cyst and to send the patient to the subfrontal approach, because we were able to remove almost completely, but not the part that was at the level of the infundibular recess that we left in place. This patient recurred after some time with a small residual at this level after the radiotherapy. And after the radiotherapy, we were very annoyed by this fact, because we were in shortage of weapons against the tumor, and endoscopy was extremely effective because the residual was very small. It was very easy to reach because the ventricles were large. It was very easy to recognize with the endoscope. And finally, for us who had already a little experience with the endoscopic ultrasonic aspirator, after coagulation of the choroid plexus, we were able to resect the recurrence post radiotherapy completely, perforating the tumor scenario, like with the endoscopic third ventriculostomy in a patient who had already a complete pan-hypopituitarism without inducing any further hypothalamic damage, and the removal was complete, So that was a very, very nice. We have used this approach on post-radiotherapy recurrences in 3 or 4 cases, if I remember properly, and we are very satisfied about these results. We have put together our experience of endoscopic ultrasonic aspirator in Naples and in Berlin by the series of Ulrich Tomale, and in this series of 64 cases, craniopharyngiomas are the most numerous cases of the series. So 17 cases in the 2 departments have been treated with, not with endoscopy, with endoscopic ultrasonic aspirator. So the series is still under evaluation, and it will be presented by Ulrich Tomale at the ISPN in Toronto, and I hope he will have the possibility to focus a little bit on this subpopulation of craniopharyngiomas. I have no final results for the moment, but I can anticipate that it is again not the final solution for craniopharyngiomas. We have to wait for some other things. So it's a very useful tool, but not the final solution. So in conclusions, the ventricular neuroendoscopy in craniopharyngiomas, very useful tool in the multimodality treatment. Cystic craniopharyngiomas are very nicely addressed by this surgical technique, and the preoperative management of hydrocephalus is extremely effective, especially in acute cases who present with a severe loss of visual acuity, where they cannot wait for scheduled surgery through the nose. In these cases, the preoperative management of hydrocephalus is very effective. We can implant an intracystic catheter in case you want to do intracystic treatment. Can be used as a palliative surgery, both in recurrences and in cystic recurrences when there is nothing left to do in your therapeutic armamentarium. And of course, removal of the cyst wall and complete removal is really very, very rare. So the real conclusion is that there is no final solutions in craniopharyngiomas nowadays. Neuroendoscopy has been a fantastic revolution, but could decrease a little bit probably the complication of the endocrine complication through the nose, but still this must be demonstrated on a larger series, and the meta-analyses are still a little bit controversial about these issues. Certainly the best policy remains in children, the master all techniques as much as you can, or rely on the best colleagues if you don't master everything. This applies very well to me. I only do ventricular endoscopy, and I do not do endonasal surgery because I don't have the background of the adult pituitary surgery, and I rely very much on the group of Paolo Capabianca and Luigi Cavallo, who do that very well, and with whom we discuss our patient, and we work as a single surgical team together. So really put the best from your colleagues and from a multidisciplinary work. Tailor the treatment. The most important progress, I mean, is the classification of Stéphanie Pouget in the last year. Identify the type 0 that is a candidate to surgery, a possibility to complete removal. Identify the type 1 that is a candidate to complete removal, and identify the type 2 that should never be removed completely because of the hypothalamic damage, has been probably the most important progress. If you stand by this and you rest attached to this kind of classification, you will never do stupid things with your patient. Spare the hypothalamus always, anytime you can, and don't enter into the hypothalamus, and don't be too aggressive if the tumor is infiltrative of the hypothalamus. And another lesson that I learned late in my career, do not delay the adjuvant treatment if there is a residual tumor. It's useless to wait if the residual will progress. It will progress, there is no doubt about it. So please use radiotherapy as soon as your patient can be submitted to radiotherapy, and take the possible advantage every time from the adjuvant treatment. Send to the radiotherapist the smallest possible residual. This is your ability, this is your skill. Leave be as aggressive as you can to leave the smallest possible residual without harming the patient. And this is your challenge, the challenge of the pediatric neurosurgeon at this time, certainly. Thank you very much, and please stay with us for the hands-on workshop that has been anticipated. 5 full days of complete immersion in neuroendoscopy are very important to master all kinds of techniques taught by the best surgeons of neuroendoscopy in the world. Thank you very much.
Well, thank you very much, Giuseppe, for a very illustrative, very informative lecture and very important conclusions. Thank you very much. I just will remind the audience that there is a possibility to type your questions in the question and answer box. And after the next lecture, we will read it for you. And the presenters will have possibility to answer. Or they also can type the answer directly if they want to. So now it's my pleasure to present Hanneke van den Santen. She is a professor at the Pediatric Endocrinology in Utrecht, and she's also a leader of a working group in the International Society of Pediatric Oncology on craniopharyngioma, and one of the co-authors of an important document, which is a treatment recommendations for childhood-onset craniopharyngiomas. So I'm very glad that you accepted our invitation, because we really need your perspective on this case. Please.
Well, thank you so much. It's an honor to be invited, and I think it's really important that we talk to each other as endocrinologists and as neurosurgeons, because I greatly respect your work, and also we see sometimes the very bad outcomes related to surgery or the tumor itself. So we have to be in touch to see how we can improve outcomes. So I'm not an oncologist. That's my first disclaimer, because I will present some new treatments. But as the chair of the craniopharyngioma working group, I think I have a good input from the oncologist to give you this presentation. And to start with, so of course you all know craniopharyngioma. It's been presented in the last 2 presentations also. Its location is most often in the suprasellar region, in the sella turcica. It's a rare disease, and in our country we just have 10 children per year in the whole of Holland. So just to illustrate how rare it is, 30 to 50% present at childhood. And of all children with brain tumors, it's around 1 to 4% of all brain tumors. And it has a bimodal distribution with a highest peak between 5 and 14 years of age, and then again in the elderly. And as was already said, it has a high rate of survival, but a high percentage of morbidity. And then if we zoom in on the anatomy, why is this morbidity so high? Here you see the location of the craniopharyngioma in the region of the hypothalamus, the optic chiasm, and the pituitary gland, which is exactly why we see the late effects and the adverse events happening because of this location. And also, as was already mentioned and emphasized by the last speaker, our aim as physicians, as doctors, should be to do least harm. And that's, I think, my most important take-home message, because as was already emphasized by the previous speaker, you do not want to touch the hypothalamus, because if it's damaged, then your whole life will change. And I will present a case to illustrate this. So I made this figure about hypothalamic dysfunction. You see the hypothalamus in light green to show you all the functions of the hypothalamus. And everybody knows that, of course, it stimulates the pituitary gland for all the pituitary hormone, and the posterior side for the antidiuretic hormone, leading to the central diabetic insipidus, which is now called AVP deficiency. But next to it, it has many other functions. So it also stimulates your autonomic nervous system. And when you have hypothalamic dysfunction, you also develop the temperature dysregulation, dysregulation of circadian rhythm. Your energy expenditure goes down. And lastly, it has the satiety center in the hypothalamus. And if your hypothalamus is not working properly, the signals coming from your gut and your fat cells in your stomach, who are supposed to tell your hypothalamus that you're satiated, aren't integrated well. So these children have 24/7 hyperphagia. They're always hungry. And then the hypothalamus is connected to other regions of the brain. And this is why they also develop behavioral problems if the hypothalamus is damaged. of course, also vision is a very important adverse effect. And it's interesting that when you talk to neurosurgeons or the working group of low-grade glioma, it's all about vision. And in the craniopharyngioma, it's more about hypothalamus. But in fact, of course, both are extremely important for the children. So is it a benign tumor? So working in the Maxima, it's a cancer hospital, the parents and the patients almost feel guilty that they're also in this oncology hospital with a benign tumor. However, if you look at how it behaves and how difficult the surgery is for US neurosurgeons and how outcomes are, we may better call it a low-grade tumor in a very malignant place. And this is a sentence that I borrowed from a neurosurgeon you may know, who stated, "There's perhaps no other primary brain tumor that evokes more passion, emotion, and as a result controversy than the craniopharyngioma." And I think that's a very nice way to phrase it. And at the patient days, which I organize in Holland, we've now said it's a low-grade tumor. It's not benign. But it doesn't metastasize. In that sense, it's benign. And just to show you what the hypothalamic dysfunction can do if you do a complete resection in a Puget grade 2 tumor. This is a girl who I know very well. She's now 19 years of age. I just transferred her to the adult clinic, and I met her when she was age 4. And you can, of course, see the large craniopharyngioma, grade 2. She presented with weight gain and headaches. And at the time, that was already 15 years ago, she did get a complete resection, and parents were very happy because the girl was cured. But then the problems start, and you can see her growth chart with the BMI, which was already high at the time of surgery, but after surgery exploded into the sky. She's now 210 kilograms at age 19. And this is a phrase that her mom told me, and which I will never forget. And she says, "The day I took my daughter to the operating room is the day that I lost my daughter. And although she survives and she's still here," not to accuse the neurosurgeon of anything, but to illustrate how things have changed in her life. She's now morbid obese. She has type 2 diabetes. She has a panhypopit. She has a diabetic insipidus with a bad thirst regulation. So she is adip6, so she doesn't sense when she has to drink. So her sodium goes up and down. She has a disturbed day-night rhythm. She has severe hypothermia. Her vision is low, and she has neurocognitive deficits, especially in memory and attention. But the most severe problem for parents is her behavioral problems. She steals, she lies, she rages when she doesn't get the food. And if mom doesn't lock the door, she will go outside and steal literally food of the neighbor's apartment. So she has 24/7 video surveillance. So you can imagine this is a disrupted family life, and this is not what we aim for in our treatments. So together with the craniopharyngioma working group, last year we finished the standard clinical practice recommendation. You can find it on the website of the CEOP working group, in which we try to summarize the current treatment recommendation for craniopharyngioma, which of course you have this emergency situation or the next phase of the treatment. So of course, if there's a hydrocephalus, you have to release the pressure or aspirate the cyst fluid, which was nicely shown. And then subsequently, you have some time to discuss with your multidisciplinary team what would, in this specific child with this specific tumor, be the best treatment. And I agree totally with the previous speaker. If it's something that's not in your expertise, you should refer the child to a center where it is done. And it's amazing to see that even within Europe, sometimes centers operate 1 or 2 children with a craniopharyngioma per year. And we did state with the working group that maybe this is something we do not want to aim for anymore in 2024, but you should aim to refer the patient to a craniopharyngioma expert center where neurosurgeons work and multidisciplinary teams are present who see, and there you cannot say a number, but maybe at least 8 or 10 per year to improve your outcomes and to improve your experience. And in this multidisciplinary team, you can set the best treatment for your patient at diagnosis or at relapse. And sometimes it can be wait and scan. If it's a chance finding, sometimes it's okay to wait and scan for several years and have the child an intact hypothalamic pituitary system while growing into puberty, while growing into adulthood. Sometimes you can do the gross total resection. I agree with the previous speaker. When it's a grade 0 Puget tumor or grade 1, you can have a great outcome with a complete resection and no tumor left. Also, for the grade 2 tumors, complete resection is not recommended anymore. And Herman Müller did a big study trying to see what's best to give upfront radiotherapy or wait until it progresses. Unluckily, the study was never fulfilled because of low patient numbers. So this is something that's still no evidence for. But there are advantages to directly give you radiotherapy, but in young children, it can also be okay to wait for a while to see if it recurs. And then we had the intracystic therapy. In the old days, they would have given bleomycin even, but there's been some reports of cyst leakage with the chemical meningitis, so bleomycin is not done anymore. But now interferon therapy has been given to several children. Some cohort studies have been published on it. Unfortunately, the interferon isn't available anymore, so this is also something we cannot recommend. And if you so in how many children nowadays do we see this devastating complication? These are numbers of the Netherlands, which we published last year. And then you can see that in around 90% of cases, there's an anterior pituitary dysfunction, and around 80 to 70% a posterior pituitary dysfunction. And this means that these children have to take medications 4 to 5 times a day. And again, when there's a diabetic insipidus with adipsia, that means that you have to monitor your fluid intake the whole day. So what are the risk factors for the hypothalamic damage? It's the Müller grade 2 or the Pouget grade 2. And in those large tumors, a complete resection, but we also see severe hypothalamic damage happening after partial resection, even in the grade 1 tumors. And currently we're performing a study to see what is this, because sometimes our neurosurgeons who are super experienced will say, Hanneke, I did not touch the hypothalamus, but then even so, we see these BMI curves going up, behavior changing, and we think there's maybe a role also of inflammation causing the hypothalamus to dysfunction, and it could also be the result of repetitive brain injury, that you didn't touch the hypothalamus itself, but by tracking on the tissue that the hypothalamus now doesn't functioning so well after surgery. So what about radiotherapy? So does radiotherapy itself damage the hypothalamus? We're not sure about that. There's been a European survey amongst radiation oncologists, and about 50% of radiation oncologists say that the hypothalamus is fairly unsensitive to radiation damage, but 50% says that the hypothalamus is very vulnerable to radiation damage. So we don't know. So this is something that we have to study in the coming years. However, we do know that radiotherapy can cause a hypopit, but also in the long-term vascular damage and cognitive impairment. So again, the younger the child, the more you would want to refrain from using radiotherapy. So surgery has its complications, radiotherapy has its complications. So we are in need for alternative treatment strategies. And this is a slide about the interferon that has been used for the cystic lesions. And you can see in the blue line that the freedom from subsequent progression was really very much improved after the interferon treatment. So as already has been mentioned, for the craniopharyngioma, there are two types, the adamantium craniopharyngioma and the papillary. The ACP craniopharyngioma is mainly seen in childhood and has been shown to be caused by an activating mutation of the CTNNB1 gene. And this causes an overexpression of the beta-catenin protein, and this activates the Wnt signaling pathway. That's different than in the PCPs, where there's a BRAF alteration, which disturbs the RAS MAP kinase pathway. So does this matter? Yes, because this may give us new treatment possibility to avoid perhaps the negative consequences of the surgery or of the radiotherapy. And this is a nice paper written by, amongst other, Todd Hankinson, and it gives a very nice overview of the possible treatments, where we could perhaps try to develop new therapies. So as I said, so most ACPs carry the mutation in the CTNNB1 gene, and these point mutations, they prevent the binding of the GSK3 beta to the beta-catenin, which results in the overactivation of the Wnt pathway. Then you have the MAP kinase pathway, which is involved, of course, in many cell processes and helps to regulate cell proliferation, survival, differentiation, and motility. And also overactivation of this pathway will cause cell growth. The PD-1 is a very important protein that acts as an essential regulator of the adaptive immune system. In situations such as cancer or low-grade tumors, the PD-1 expressor tumor infiltrating T cells are made inactive by the PD-L1 that's expressed on the surface of the tumor cells or of infiltrating tumor cells. And this could be made inactive with compounds such as nivolumab. So if you, and this is also a very nice review, you may have seen it, which is just published in the Endocrine Reviews of John Epps, amongst others. And this is a very nice model they made about how the complex, also paracrine signaling within the ACP craniopharyngioma may work and have now been described, including the known targetable pathways. And one of the targets could be the inflammatory pathway. In ACP cysts mainly, there's a significant inflammatory component. And there are some arguments that formation of the solid parts, also inflammation has a big role. Taking this further, that means that targeting IL-6 would be a potential treatment for primary cystic craniopharyngioma. And as you can see in the figure here, especially if you look at the last three figures, you can see that after tocilizumab, you see the cyst really declining in this patient. So this could be a way forward, especially for cystic craniopharyngioma, because this, actually I explained this already. So the IL-6 promotes the epithelial to mesenchymal transition. It increases the migration of the ACP cells, and it's already been shown that it is associated to the ACP recurrence or progression. Tocilizumab is a very interesting compound for childhood craniopharyngioma. It's a humanized monoclonal antibody against the membrane-bound IL-6. So this has been taken forward by the CONNECT consortium, and this already started in 2022. And the study is already open in the US and Australia. They're recruiting patients. I'm not sure how many they recruited at the moment. In the summer, it was around 6 or 10, I think. Unfortunately, it's not open in Europe yet. We are dealing with a lot of legal constraints. And for this reason, we now do give tocilizumab in some cases off-label, but we very much hope to also open this trial in Europe soon. The CONNECT consortium also opened another trial, which is already open also in the USA and in Australia. And this is with binimetinib, and this is to target the MAP kinase pathway. Because as I showed in the figure also, it has been shown that this also, even in the ACP, could be a way to target the craniopharyngioma. I found this very recent publication in the European Journal of Endocrinology of a French multicenter study. I think was a very nice study, also with the BRAF mutation PCP patients. These were adult patients, by the way, but also here it was shown that there was a very nice response to the neoadjuvant treatment. So I think this is a very promising way forward, and it's very exciting, I think, to see if this could also be something for the ACP in childhood. Another trial which is upcoming and is already running in the US, but which we will open in Europe also, is the PNOC, so that's the Pacific Pediatric Neuro-Oncology Consortium, who have started a study using nivolumab and Day-101, which is tovorafenib, for the treatment of newly diagnosed or recurrent craniopharyngioma. So the rationale for the combination of these drugs is for the tovorafenib, it's the pan-RAF kinase inhibitor, and it inhibits both the BRAF V600 and the BRAF fusion alterations, and it has a very good CNS penetration, and it's given weekly instead of daily, which is of course an advantage. to combine this with the nivolumab, which is the anti-programmed PD-1 monoclonal antibody immunotherapy for the PD-L1 expression, which is mainly found in the cyst lining. So to combine these two, this may be a way to attack the craniopharyngioma in different pathways. This is the clinical trial scheme. So the idea is that patients get one of these drugs or both before surgery, so that during surgery a biopsy can be taken, and we can also see if the drugs really enter the craniopharyngioma cells. And then depending on the outcome, it will be chosen to randomize further in the treatment arm or to be off therapy. So to conclude, this is our current treatment recommendation. It's surgery, radiotherapy, but there are really things coming on the horizon, and I think this may really be a way forward for childhood craniopharyngioma, because of course the tumor sometimes already has damaged the hypothalamic region, and if we can prevent touching it and keeping it the way it is, but perhaps shrinking the tumor by systemic approaches, well, this could be a nice way to prevent worse outcomes. So for the future, it's good to be aware of the adverse effects and the changes observed after neurosurgery. There is an increasing knowledge on the molecular features. Studies are starting up, hopefully soon, also in Europe with the new medications. And I think centralization of care is something we should really aim for. For now, it's limit the neurosurgery not to the hypothalamic region if possible, and select the right patients in who you can do a complete resection in, because of course it's it's the best option to get the whole tumor out, and centralize care to improve outcomes. And maybe to show you, this is the 2 cohorts I work in the Maxima. We've now since 5 years, we are seeing all the children in Holland, which is still only 10 per year, but even so. And then if you look at hypothalamic syndrome, you can see that centralization of care. And I don't think this is just the neurosurgery. I think it's also the whole multidisciplinary team, of course, that we have for the signs and symptoms of hypothalamic syndrome, such as the obesity. But it does help to see more children, larger cohorts, not just for the neurosurgeon, but also for the endocrinologist and for the physiotherapist and the oncologist to get expertise on this disease to move forward. So take-home messages: ACP and PCP are 2 very different tumor entities. However, they may share some molecular pathways. So maybe for systemic therapies, we can learn from the 2 different cohorts. Morbidity can be severe and can be associated with the surgical intervention. There's an increasing evidence that targeting the MAP kinase pathway may be useful for both tumor entities. Inhibiting IL-6 may be of therapeutic value in the ACP. Perhaps we should do a combination therapy like PNOC is suggesting, and refer to an expert center if possible. So thank you so much for the invitation. I will be happy to answer any questions.
Well, thank you very much. This was really a nice presentation, reminding us that this is not only surgical disease. So it's very important. Thank you very much. So the first I have to announce that our last speaker, Herman Miller, was not able to join us, which is a pity because he has done a tremendous amount of work on following up these kids and showing that the outcome is really complex. But please check his publications. He's in a lot of them. So this is a name to follow. So maybe next time. So for now, I thank the speakers, and I will open the discussion. Please, Raphael, would you see if there are any questions in box?
Yes. Well, first of all, also from my part, thank you so much for the 3 great speakers with very important messages, I think. So I know we have almost 80 people online, I think, and so that was great. So I will go with the first question that landed in the chat box, and it was but it came in first for Sergey, and the EANS Matveyevs is asking, if a supraorbital approach is chosen, Sergey, which side would you choose? What are your principles in the choice of the side?
Yes.
So, you know, right or left supraorbital. Yeah.
Yeah. So thank you for this question. So the side of the approach depends firstly on the working hand of a neurosurgeon. So if it is right-handed, so an approach may be performed from the right side. But of course, it depends on the localization of the tumor. If the major part of the tumor is on the right side and we use the subfrontal approach, it will be performed from the right side. If there is a cyst or the part of the tumor in the anterior fossa on the left side, we shall choose the left-sided subfrontal approach. The same, but the vice versa for the transcallosal one, because it is from, for example, from the right to the left, we better see the opposite side of the third ventricle than the ipsilateral side. So if the major part of the tumor is localized in the left side of the third ventricle, or more basically, we shall use the right side transcallosal approach, and vice versa. So this is our opinion. Yes, for this question, yeah.
Thank you very much, Sergey. And I will just go on with the second question and then give back to Radek. There was one question by Yehuda Soleiman that Giuseppe already answered, but I just wanted to follow up because I'm not sure that everybody actually goes to read, and I think it's interesting. The question is, do you treat predominant cystic craniopharyngiomas with placement of Ommaya followed by proton and radiotherapy? Or do you go for resection of the cyst? What is your approach in the mainly cystic craniopharyngioma? That was for Giuseppe. Yeah.
I answered to this question by saying that it's true that if you put a catheter inside the cyst, you can obtain a very good shrinking of the cyst, but still the volume of your target for radiotherapy remains relatively large. You can have a cystic residual that goes from the infundibulum to the foramen Monroe, or a shrink that really does up to 2 cubic centimeter at the level of the infundibulum. Whereas within more extensive endoscopic removal, paying a lot of attention just to remove the part of the cyst, as I shown in the video, that is very easy to remove because it is simply floating inside the third ventricle without any adhesion to the largest part of the cyst is just floating to the ependyma. And once you shrink the cyst, aspirating the fluid, all this part that could be 95% of the tumor can be easily removed with the endoscope without any harm to the hypothalamus. So I just stop, as I have shown in the video, when I find the insertion of the cyst inside the hypothalamus. That I do not touch. I leave that part, and sometimes, as I have shown on the post-operative, we just see some very small calcification infiltrating the hypothalamus. It is a very small target for proton therapy. We try to standardize our treatment, sending all craniopharyngiomas to protons, and we send them to protons, and we have good results so far. It's been doing that for the last 5 years. And we were very late in Italy in the setup of the protons, but finally in the last 5 years we have been able to send all our craniopharyngiomas in Naples to protons, and we are happy with that.
Yeah.
Sergey, yes.
Yeah, I may add something. So for the primary tumors, we try to use the surgical approach, even if it is cystic one. Because basically there are no pure cystic craniopharyngiomas. So in any case, there is maybe a small solid part somewhere on the basal part of the tumor. So in these cases, as a primary treatment, we try to perform the near total removal, and then, if necessary, to proceed with irradiation. But in cases of recurrences, in these cases, the majority of craniopharyngiomas are really cystic. So, and it is not so easy to go through the same approach basal one or transcallosal one for the removal of the recurrences. So in these cases, we may use the Omae reservoir, try to, as Giuseppe said, to shrink the cyst, and then to proceed with radiotherapy. But the main goal is to perform the maximal shrinkage of the cyst and keep it the same size during irradiation. Otherwise, after the start of irradiation, it may again enlarge, and this part of the tumor will be out of the field of irradiation. This is a very important thing.
Thank you very much. I give it back to Radek.
We have a few other questions, and I think there are 4 of them or 3 of them from Ahmed Najjar that I think are directed to Hanneke. It's about the experience with interferon and blomycin. You've touched it already. Then why actually the interferon is not available? What is then the current intracystic therapy opportunities? And finally, if tocilizumab is approved or it's still experimental treatment in this regard.
Yes, thank you. So why it isn't available? I think it's production. It's the lack of the numbers. So it's not interesting for the companies to make it. So that's not something we can help, unfortunately. So currently there's not a real therapeutic option in this sense. Next to putting in a catheter, and sometimes you can even see when you drain a cyst that it keeps being shrunken and it doesn't recur even without putting in interferon. But it's a big problem, and we did have some really good results with the interferon therapy, but well, it's not there anymore. And for the tocilizumab, that's really still experimental, so it's off-label, and we don't encourage that people give it off-label out of trial. But so we've written one case report, and this was a girl with a 5th recurrence of a very cystic craniopharyngioma. She already had surgery, I think 3 or 4 times. She had radiotherapy, and then again this large cystic craniopharyngioma came, and for this girl we gave tocilizumab off-label, and she responded really well, but we don't know for how long, and that's why we need the trials, of course, to have more numbers to really get some experience on what this will do.
Yeah. Do you have any personal experience with pegylated interferon?
No, I don't, but I know there's a colleague, and well, maybe you do, but no, we don't. But I know somebody is writing a cohort down, and it's going to be published soon. But and those results were very good, I think. So, but I don't have the experience myself. Yeah.
But it's not an intracystic therapy actually, because it's given I mean, systematically. Yes.
Yes, absolutely. I think it's a very nice idea. Yeah.
Okay, then maybe regarding the discussion we just had, I mean, we have some patients where we actually put in a catheter because there was a predominantly cystic craniopharyngioma, and we just tapped the cyst 1, 2, 3 times without even giving interferon, and it also enabled us to buy some time because it was young patients, and we could postpone the surgery even with some years without really seeing an expansion of the solid part of the tumor. And the idea was maybe it's a difference to be operated before the pubescence and after pubescence. So what is your opinion as an endocrinologist on this? Is there really a point?
Yeah, very good question. I think the longer you can mature and grow on your own hypothalamic pituitary function, it's for the best. I mean, as endocrinologists, we can replace the pituitary gland really well. So we also treat children with congenital hypopit, of course. So I mean, we can replace it very well. But to have the hypothalamic pituitary region distorted in puberty with an adipsic AFP deficiency, with a hydrocortisone, and then with the hunger and the satiety. So as soon as it is a little bit hypothalamic, more than just pituitary, then it becomes very difficult. So, but that's the balance, because I also agree with one of the previous speakers who say if it recurs and it recurs really big, then you than you maybe would have wanted to give it previously, because then your radiation field would have been smaller or your surgery would have been less. So it's a super difficult discussion, which we also always have in our multidisciplinary board.
And I see another very difficult question here among the participants, very personal one. Mentioning her husband who's been treated for craniopharyngioma with surgeries and radiotherapy, and being pan-hypopituitary. So and the question is whether there's any effective treatment for that. So I think the answer is quite simple, I'm afraid.
For what? For the
pan-hypopituitarism.
Pan-hypopituitarism.
Oh, no, so you can treat the lack of hormones, but we can never cure pituitary insufficiency. No, and that's unfortunately not possible. But you can replace the hormones that are lacking. Yeah.
Okay. I don't see any other questions. So perhaps one short question or two short questions to Giuseppe, because you mentioned your cooperation with transcranial surgeons. At your institution, what is the real limitation of this approach? Because someone says that this is the lack of this sphenoid semus. Then someone says that we have a drill, so we can actually drill to the sella, but then there is an intercarotid distance. So what is a practice at your department? How young the child can be to be operated transcranially, from your experience? We don't hear you, please.
Yeah, sorry. And as I said, we don't do endoscopic endonasal in our department. We send the patient to Luigi Cavallo, and we have big problems in the first 2 years of life. Big problems. If there is absolutely no sphenoidal sinus, even masters like Luigi Cavallo tend to say no. But it is also true, unfortunately, that the craniopharyngiomas in this range of age are so big that they rarely approach them with the endonasal approach. And unfortunately, they leave these very serious cases below 3 years of age, unfortunately, to microsurgical removal. And these are the class of patients that are the real challenge for us. They are so far from the puberty, and their tumors are so aggressive, and sometimes they are so big, and their visual acuity is so low, and even if it is not clearly evaluable, because they are 3 years of age, you know that they can be completely blind on one eye. And this class of patient is really very, very difficult, because making a transcranial approach below 3 years of age in the supracellular area with the aim of being a subtotal, it is you really must be a very, very good surgeon and very, very experienced in pediatrics. And in real life, unfortunately, nowhere in the world these patients are really completely, fully centralized. And unfortunately, you can say what is your experience, but my experience does not reflect the world experience, that unfortunately tend to have an incredible peak of very high expertise and very low level. Sometimes it's not because the neurosurgeons are bad people. Sometimes they don't have the network. Sometimes they don't have the time to transfer the patient because there is an emergency. So it's real life is very different from what a standardized European network is able to produce. And we have to keep into account this even in very developed countries sometimes.
Yeah. Sergey, please.
Thank you. So I'm quite agree with Giuseppe. But nearly all patients with craniopharyngiomas in our country are centralized to Burdenko Institute. That's why we perform about 40 to 50 surgery a year in children, I mean.
Wow.
But I'm quite agree that the transnasal surgery is rare, especially in young children. So to many circumstances, that's why we perform the transcranial surgery. And, many times I say to my doctors that nowadays it is much more difficult to perform the partial or subtotal removal than to completely remove the craniopharyngioma, because you have to know the place where to leave these small parts of capsula just near the hypothalamus in the proper way, not to destroy this part of the world. But to completely remove it, it's very easy, but with the very bad circumstances. So, and concerning, I would like, if it is possible, I may say some remarks concerning the radiotherapy, which we have discussed. We have analyzed so these two possible ways. So completely remove the craniopharyngioma, or to perform the partial subtotal removal, and the catamnesis of the patients with radiotherapy. And we revealed that radiotherapy itself does not perform the additional damage both to the visual functions and to the hypothalamic functions. So we have to differentiate the hormone deficiency, which occurs nearly in all the patients, and the diencephalic damage. So we cannot improve the hormone deficiencies, but we can avoid the hypothalamic damage, and this is the main purpose of surgery. But radiotherapy does not make worse to these functions. So to our view, it's rather safe treatment, and it may be used. Moreover, we have analyzed the quality of life in these two groups of children, and it appeared that in the group of subtotal removal plus conformal radiotherapy or proton therapy, the amount of the rate of recurrences are the same, but the quality of life is much better than for the attempts of the radical removal. So, and the last reply concerning the genetics. Of course, we differentiate these two types of craniopharyngiomas, but recently our group of investigators in our institute revealed the third gene, the APC gene, which regulates the beta-catenin pathway. So this may be the third gene which is involved in the craniopharyngiomas biology. This paper was written, to my mind, in the Neuro-Oncology a couple of years ago. So this is my reprise.
Yeah, and I can just support your claim about radiotherapy with the reference to a very nice Polish study published just last year, where they show that by surgery, added the risk of endocrinopathies with almost 60%, 80%, whatever. For radiosurgery, it was like from 0 to 3-7% maximum.
Yeah. So of course we speak about the conformal, the stereotactic radio surgery or proton therapy. So in these ways we can perform the proper field and to protect the functional zones of the brain. And in these cases we have very good results. Yeah, thank you.
But it's true that, and I think Giuseppe said it, that we had a panelist discussion at the AACNS where I think Merchant presented his proton therapy results and some other presented the conformal radiotherapy. And there does not seem to be a significant difference between the two techniques, I think, right?
Yeah.
So we have another questions from Professor Soleiman to Professor van Santen. Based on your experience, should we treat patients with targeted therapy off-label? And if yes, which drug would you suggest based on your experience? Should we use it only for recurrence or even upfront?
Yes, nice question. I think it's too early to start up front, but considering the enormous damage that we sometimes see, you would want to start up front, but I think it's too early. I think we have to wait the clinical trials, and I think we shouldn't aim for that. I do think for recurrent disease, for cystic recurrent disease, there can be a role for the tocilizumab, but also here it's still off-label and it is experimental. So yeah, I hope that we will all do this within trials.
Maybe I can just follow up with two short questions also. The first is, we were talking about the very young with the very large craniopharyngioma, and we had one child, if I'm correct, maybe 2 years old, with a very large. We did a biopsy, transventricular endoscopic biopsy, found a target, and treated with a MEK inhibitor, and that little child now was able to grow, I think, to 4 years maybe, with a kind of a stable disease and a good neurological and endocrinological status. Anything like this in your experience? Because we tend to think, oh, large tumor, we need to go and resect, but maybe we can go just for biopsy in this very particular group and then
I
do
agree.
a targeted
No, I
therapy.
agree. I think this is the way forward. And I was talking to Darren Hargrave, is a pediatric oncologist from Great Ormond Street, and he's also very active in the low-grade glioma group. And we were even talking about maybe we should combine cohorts, craniopharyngioma, low-grade glioma, because there's similarities in the genetics also, and maybe this will increase the possibility for such trials, because the things we're running into in Europe now to get the Connect trials open in Europe, I mean, the slide was 2022. We're already in 2024. I organized a symposium in Utrecht on craniopharyngioma, exciting times, in 21, and still 3 years later, the trial's not open yet. So we have to find a way how to get these trials open and running in Europe, and maybe by combining it with other tumor groups would be a way forward. Yeah. I also saw a question about the growth hormone treatment. Maybe I can quickly respond. So with the Growth Research Society, we made a consensus document, and because craniopharyngioma is a low-grade tumor, just like pituitary adenoma, there's no reason to think that growth hormone, if proven growth hormone deficient, will give tumor recurrence. So you can safely start your growth hormone. We do often wait for the first 3 months. So we have surgery, then you have your first MRI 3 months later. And if everything is stable and good, and you've proven your growth hormone deficiency, then you can start. But you don't have to wait a year or be afraid of recurrence.
Thank you very much.
Yeah. Everybody should hear this.
Yes,
this
is so important. This is so important coming from you. We still discuss for each patient, our endocrinologist asks to the oncologist. We have to discuss a multidisciplinary session, and we have to put a verbal and written consent that the whole team says that the growth hormone can be done. And this is useless. It's a waste of time. I mean,
you can use the paper of the Growth Research Society, because it's we also stated it in the COP recommendation. So
absolutely.
Absolutely agree. There was a discussion in the literature if a growth hormone treatment may cause a recurrence of craniopharyngioma, but it wasn't supported, and I'm quite agree that it should be started as soon as possible.
I think I just perhaps I should mention for the audience that Hanneke, you are organizing these difficult cases meetings.
Yes.
We will have one in just 2 weeks or 10 days.
Yes, we will. Yes. So everybody's very welcome. If you have difficult cases, we discuss them with the whole forum of the craniopharyngioma working group. So absolutely.
Yeah. So I think it's now 6:30. So we've had a very nice webinar. I really appreciate the time and efforts from all of you. I appreciate the interest from the audience. This is a never-ending topic. We could discuss several days, and there's a new therapies emerging. So we will keep up with this problematic later on. But for today, I thank you all, the presenters and the audience, for the interest. And remember, if all these lectures are recorded, so can be available among other places on the YouTube channel to the EANS. So thank you very much. Have a nice evening.
Thank you. Thank you very much.
Thank you very much.
It's been a great pleasure.
Forward to see you.
Bye-bye.
Thank you. Bye-bye.